When I was giving a report on her, I was not told what was the last echo results. And when I looked it up, her echo was 40%. So her EF was 40%. And she had moderate left diastolic failure. So here, oh, and a huge part of the left ventricle was akinetic. So the left ventricle is not working well to begin with, okay? And when I looked at her, the first thing I did, let's go back to the lab. So she had a high CVP, a high RVP, a high PAP, a high PAOP, a low cardiac index, and a really high systemic vascular resistance. Now this lady was receiving NEO out of 160. NEO was so high in this lady. I did the whole passive leg raise on this lady, and the JVD did not change at all. I even raised the head of the bed to see it will go away. It did not go away. So the JVD was really pronounced, which was telling me that it was an obstructive issue with the heart. And taking in consideration that all the pressures were high, I attributed this increase to the high NEO, okay? So the first thing I did was I went from NEO from 160 to 80. I waited 10 minutes, blood pressure came down. Now, most of us don't give the patient enough time to compensate on their own. A lot of patients, and we see this with orthostatic hypotension, when a patient stands up too fast and they get lightheaded, the body will compensate and the vessels will constrict, and eventually, within seconds, the patient will be able to maintain the blood pressure. Or minutes, but the body compensates, which is my point. Sometimes we start coming down on the pressors and we don't give the patient enough time to compensate. I say 10 minutes to 15 is a good trial. So I came down to 80. In the next 10 minutes, so these are the original vital signs and the map. So when I came in, she was a 120 heart rate. The systolic blood pressure was 110, and this one was barely 65. Came down to 80, heart rate came down to 100, systolic blood pressure remained the same, and the map was about 60, 70. I waited 10 minutes, I came down to 40, heart rate came down to 80, blood pressure stayed the same, and the map now, the systolic number was a little higher. So what happened here? This is within 20 minutes of my first 20 minutes of my shift. At the end of my 20-minute mark, I rechecked, relabeled my transducer, rechecked the CVP of the patient, and the CVP at this point went from 20 to 12, which is a more manageable number. Now, we want the CVP to be between 2 and 6. However, if the patient has sepsis, we want that to be above 8. And if the patient has chronic hypertension or COPD, we want the CVP to be above 12. So this lady, I didn't want the CVP to be too high because she has already a compromised left side, okay? However though, I told you that the pressure, if the pressure increases right here, will affect this way, right? Usually with someone that has left ventricular failure, you will have crackles. I could not hear crackles on this lady because she was getting positive pressure ventilation. And the positive pressure ventilation relies on PEEP to increase the airway, the mean airway pressure. So once we increase the mean airway pressure, we are able to maintain the alveoli open and keep the fluid out. So that fluid has to go somewhere, and so it started backing up to the right ventricle, to the right atria, and eventually to the JVD. So this is what I'm saying. I did not do anything else to this patient but to decrease the pressors. This is when knowing how the pressures manipulate becomes important, because I could have let that patient ride on a knee of 160, but who knows how long the heart would have been able to maintain that. You can't ask a sprinter, a 100-meter sprinter, to run a marathon at the same speed. It's impossible. And asking a sick heart to do it is just not appropriate. So now, once the heart rate came down, NEO to me will not be, once the heart rate came down to 80 and we maintained it like that, the best idea was to move from NEO to LEVO. because levo will help us with maintaining blood pressure by increasing the activity of alpha-1 receptors, but it also will give us that extra push that the heart was needing with the beta activation, the beta 1s. Okay, so this is when the critical thinking, and this is when nurses really have to advocate for the patient, because increasing the systemic vascular resistance on a sick heart is not the best thing to do. It's not. So even though the order says do neo, just because the order says do neo, it doesn't mean we have to do neo. We have to do what's best for the patient, and we have to have a good clinical reason of why to change it. At this point, I think for this particular patient, the best drug was moved from neo to nevo, which didn't end up happening. But the patient was off pressors by the end of that shift, which, again, you have to titrate pressors, but you have to let the patient compensate on their own. I feel that sometimes we don't give them enough chance. Another thing that you have to keep in mind is that positive pressure ventilation also decreases venous return to the right side of the heart. So now you have another factor you have to keep in consideration. When you decrease venous return when you increase PEEP and when you increase volumes with positive pressure ventilation, that pushes on the main vessels on the right side of the heart. So our CVP might be low, but it doesn't mean the patient is hypovolemic. It is probably just a pressure issue. So if you notice the patient is starting getting tachycardic, the patient is getting difficult to control the blood pressure and the urine output is coming down, you have to think, is it the pressure, is it the pressors, or is it the positive pressure ventilation? Which increasing positive pressure ventilation increases the pressure in the lungs, which will affect this number right here. So there's a lot of factors that really affect the way the pulmonary circulation and the cardiac circulation. But I won't go into detail on those. I just wanted to mention epi and neo because we use them a lot. One thing is to know what receptor is. It's important for us to know what receptor is being activated, but it is also important to know how the application of that particular pressor will affect our circulation, okay, and our cardiac numbers. Okay, so let's do another little exercise really quick, and we'll come back to this thing. So, because we constantly use central venous pressure, we monitor central venous pressure often in the unit. I want to talk really quick about how the waveform looks. I am completely amazed about how some people don't really know what the waveform looks like, and each waveform has a name and a letter, and in order for us to actually believe the number that we're looking at in the monitor, we have to correlate the QRS complex with the CVP waveform. So a normal QRS complex is a P wave, then QRS, and then the T. A CVP waveform has an A waveform, an A, and then you have a C, and then you have a V. This is X and this is Y, which these two are not important at all. This is a good CVP waveform. Now, a good CVP waveform always has the A wave right after the P. It has to be right after the P. C is when the tricuspid valve, because we're checking on the right side of the heart. So we're checking the tricuspid valve. When the tricuspid valve closes, you have the C wave, and it has to happen right after the QRS complex. And the V wave is refilling, is when the atria gets preload and is filling up again with blood, or when the ventricle is completely relaxed. So you have blood moving from the atria to the ventricle just by gravity, but the V wave happens right before the T. If your waveform does not look like this, you should not believe the number. And every time you have someone on central venous pressure, you have to document a strip that has the CVP in the bottom and the EKG on the top, and make sure you label that lead, which the best lead is always 2, okay? If it doesn't look like that, you should not believe the number you're reading. Now, with that being said, we can also look at the arterial form, because we use that a lot. And the arterial form is almost the same. It's just that we are checking arterial waves, so we see the pulmonary valve closing. So the pulmonary valve closing is going to be right before ventricular contraction. Okay, so the waveform will be like this, and this will be what we call the diacrotic notch. Again, if you have either an A line or a CVP, if you have both, document both strips. Document one correlating CVP with the QRS complex, and document one with the A line correlating with the EKG. Otherwise, there's no point. Okay. Otherwise, it's really pointless to have them if we are not using them appropriately. Okay. And just to summarize, numbers you have to remember, but the biggest thing with hemodynamics is to identify where the pressure is increasing first. Is it the systemic pressure increasing, ventricular pressure? If you know where the pressure is increasing first, you'll be able to determine what's causing the issue, okay? And always check, make sure you understand the cardiac function of the patient before you start on pressors, and make sure that the patient gets adequate fluid resuscitation before we start pressors, because otherwise that's what we start seeing. 25% of the blood ejected by the left ventricle goes directly to the kidneys. If we start increasing that systemic vascular resistance, that will affect that number, and that will lead to kidney failure. Okay, we don't want that. We want to do the best for our patients, and kidney injuries are not what they need. Okay. That's pretty much it. The point I want to make is that you don't need to have an advanced hemodynamic tool to understand that the pressures are increasing. If you see someone